I feel that in Jersey we've got the unique opportunity and ability to really harness the good, but to do it in our own way. So we're not trying to NHSify the system. We don't have the same constitutional standards, and we don't have the same framework, and our services aren't provided in the same way. There's a different island context. But we want to keep our links with the UK, and we don't want to lose those educational and that workforce flow.
That was Group Managing Director for the Health Service, Rob Sainsbury, and I'm News Editor of Express, Fiona Potney. Unresolved bullying in operating theatres is affecting the care some hospital patients receive, with some staff apparently even unable to work in the same room as certain colleagues. That was the finding of a June 2021 report authored by Felix Choto, a specialist theatre nurse who spent 4 weeks assessing the challenges in Jersey's surgery services and found problems with culture, process and leadership. The report was never made public, but leaked to Express just as non-urgent operations began to resume after a months-long suspension due to non-COVID-related staff sickness. Much of that was to do with stress and anxiety in the workforce. But the apparent sickness in health doesn't only lie in theatres. There have been issues with morale reported across the service linked to both relationships with other staff and the crumbling working environment they're in. Other staff are nervous about wider sweeping changes in health, there are recruitment issues, and some are decrying the so-called NHSification going on. In this week's edition of the Bailiwick Podcast, I put those concerns directly to Mr. Sainsbury.
It's difficult, really. I think any review that highlights where you need to make improvement, we expected it to highlight where we needed to make improvement, but it's difficult to hear. I think it's multi-layered, and so your opening comments about the pandemic, that's absolutely true, and our theatre staff are actually one of the very significantly impacted groups because they often have skills in anaesthesia support, and often they are supporting critical care functions. And of course at the beginning of the pandemic that was the area that we thought would be most needed for this workforce, so they really had to step up to be prepared to work in critical care, in the theatre services that could have had some patients with COVID. So it's been a stressful time for that staff group overall. That said, I think within the report, it is highlighting what feels like a cultural issue within the department. It feels that it's been quite endemic and been there for quite a long period of time. I've never worked in a healthcare setting that doesn't have professional tension. You get that between doctors, nurses, social workers. You train in a different way and you have different approaches to things, but you generally get to the same common ground, and that usually revolves or should revolve around the patient. I think in this instance it's highlighting that we've had some long-standing issues, cultural problems that really need to be tackled and dealt with, and that goes right the way from the bottom to the top and the top to the bottom. And I welcome the report for that, because that's exactly what you want to learn. We've got to be a learning environment. Every healthcare setting has to be, and it has to focus where your attention is needed, and it's done that.
So if we just pick up on one of the cultural issues there, one thing that's pointed out in particular in the report is bullying. And we know that HR Lounge did a review of the entire government back in 2018. And that obviously found that the issues were very prominent back then. But now we're 3 years on, and we've got a reviewer for the theatre service in particular saying that that's still an issue now in 2021. So why do you think there are, in his words, a very high number of unresolved bullying cases currently in health?
So I think there's a lot of work needed in that area. We're working hard with our employee relations and with our HR support teams. There are some historical cases. Some of those cases are complex, and Jersey is in a slightly different position to other organisations where you're able to have breadth in terms of different hospitals, different sites, different functions that sometimes can be supportive in finding resolution. With time away, that's not quite as easy in a one hospital system, and in a specialist staff group as well. So it requires some specialist input, and that's exactly what we've tried to deploy now. The thing that was absolutely crucial for me is that we needed different clinical professional leadership. These are highly skilled, highly trained practitioners. They don't work in a way that is managerially set. They work in a way that's set to processes and principles of patient care. And so they need clinical professional leadership to enable them to do that effectively. And getting strong clinical leadership is the thing that we've really focused on, supporting the teams so that they can actually then really start to focus on the improvement that's required in the department.
Absolutely. I mean, leadership is paramount, and that's a topic that I'd like to return to later. But just focusing on this bullying situation for a moment, can you just lay out what is the current path for someone that might have a complaint? You know, how quickly are you able to come back to them with a solution? We've heard cases that have been dragged out for a very long time. We've been told by professionals who work in the health department now, or who have previously worked in the department, that they've been told to provide evidence stretching back months, but naturally people want a solution as soon as possible.
So I completely understand that, and I think that historically it's been too slow, and something that we've moved to very quickly is to have a quicker 5-day set fact-finding initiative, so that you can really try to get underneath something quickly and get to the position and understand where people are coming from and why they've got a grievance, or they feel bullied, or feel harassed. And that is proving to be quite successful. That's helping. So we're getting some speed. But we still have some historical cases that have been in process for a long, long time. And that's not good for anybody. And that's certainly not good in a department of that nature. I think that there's a lot of learning that's come out from that. What I would say, I appreciate people probably are fed up of hearing about the pandemic. But the pandemic has required a different way of working in health and care systems and settings. We are not used to working in a command control structure, and we're not used to working in a disciplined structure. We're a non-disciplined service. We're multi-professional services. So we're used to having debate, discussion, looking at evidence, informed decision making that is very broad in how you capture to get to the point of decision. In the pandemic, that has been really challenged because you've had to make very quick decisions. You've had to do things that sit outside people's comfort zones, working in different settings, working differently. And I think that's been a real challenge for our healthcare workers.
Do you think that might have sort of fractured some relationships?
I think it's probably exacerbated what was probably already underlying, is how it feels to me. There was already clearly a problem and clearly a cultural change that was needed. When you then add in the context of the pandemic, it's also difficult to recruit to workforce, and globally it is. Those multi-layers then really create a tension, and I feel that we got to that point, and that's what the report is really highlighting for me.
You mentioned in Jersey dealing with a bullying complaint might be a bit more difficult, given that they can't sort of have that time out. Yeah. We've heard from people as well who've told us of colleagues that have moved departments, but then they still bump into them in the corridor, which can be quite a stressful experience. Is there a way around that? Have you managed to find a solution? So
I think there is. So this is a tension throughout services in Jersey. I think this, for me, I've been here for nearly 4 years now. You are in a very small environment, and so the person that you might have conflict with could be your neighbour, your former friend, somebody you see in M&S every Saturday. You know, it's very difficult to not be in contact with people here. And at times, I think that has led to avoidance, and at times people don't want to have a difficult conversation. Often people try and choose an easy route, and that often creates even more tension, or a quick solution like let's move people, and that's not really getting underneath what the problem is. And my experience in other areas where we've had this problem, it's not just a Jersey issue, is I think as long as you approach things with honesty, integrity and transparency to try and resolve the issues, I think you get a better outcome. I think first and foremost that has to be the approach that we take. You've got to trust in the process, you've got to trust in people, but you've got to allow people to give their story and to treat their story impartially and look at what your solution could be.
Let's just touch on, what the net effect of some of these issues can be. So bullying, for example, as well as the impact of the stressful environment of the pandemic, that can all lead to morale issues. And we know that there are certainly a lot of difficulties there. We had a recent statistic, 43% of health staff sickness days are related to anxiety, stress, or depression. So that's obviously something I'm sure that you're looking at that is of concern. I know also the Team Jersey programme was kind of meant to remedy morale issues and bring people together, but the engagement in health was really quite low. So what ways are you looking at, perhaps different ways of turning things around in that respect?
Many different ways, and we've had to adapt. So I think the Team Jersey initiative was a good initiative to start to get underneath some of the historical cultural challenges we've had across the services and departments. In addition to that, there is a pandemic context. So in some of our departments and some of our services, there is clearly what we would describe as trauma, and we have to have trauma-informed support for those practitioners because they've dealt with traumatic situations, quite tragic situations with some of our patients, where we've not had a good outcome.
Does that mean kind of counselling, that sort of thing?
Yeah, very very extensive counselling and support, and a very formalised method of support with lots of different approaches for that. We've tried initiatives that are called Schwartz rounds, where you have time with the team post-event. We do TRIM initiatives, which again is looking at the trauma impact that practitioners are facing. But then there's a broader wellbeing piece. And for me, one of the most simple things that we realised in the time of the pandemic was staff wellbeing, physical movement, going and you see some of those videos that I think people probably got tired of, but they meant a lot to our staff, where people will start at the beginning of their shift with physical movement. They will do it to a song, and it was a really galvanising, bringing together part of the workforce. It's very important. We've had to build on that, and we need to do more to build on that, so that we're about to go into a wellbeing week, and that looks at all sorts of physical support, yoga, Pilates, support, Zumba, different sporting initiatives for our workforce, as well as offering counselling support, the more complex side of things with those other things that I mentioned, TRIM and Schwartz rounds. But then generally, we need much more for staff wellbeing. And I think for me, the environment is probably one of our key enablers there. And that's not great because at times throughout the pandemic and previously, our staff don't have anywhere to eat. It's been difficult to socially distance in the hospital as it is. And so staff have been taking breaks in stairwells, in areas where they've been able to try and grab time. And I'm sure that all those factors have really contributed to the need to really drive a different wellbeing agenda for healthcare. What we think healthcare workers needed to support wellbeing before the pandemic is really different post-pandemic. It's demonstrated that we have to take care of our workers.
Absolutely. Just looking at some of the difficulties that have been faced by staff and some of these cultural issues that may well be historic, but as we've acknowledged, have been pervasive in the organisation. What concerns do you have, given that the Jersey often has a lot of UK-based staff, NHS staff, agency staff? What concerns do you have that might impact on recruitment through word of mouth, that type of thing? We've heard of agency staff that have returned and have told their colleagues, not to touch Jersey as a result of this. So that must be of concern.
So I think any organisation's reputation is a big thing. We actually attract a lot of people to Jersey because they've had good experiences, and we see when you get a critical appointment, you recruit a key position, and you often get staff who follow. And so it's really important. It's important that people recognise that Jersey is a good health and care system. I think for us, the key focus has to be around how we address some of the core recruitment challenges that we have. We are part of a global workforce recruitment initiative. Healthcare is a global business. We have people trained predominantly from the UK, and most of our staff come from the NHS actually, and we're obviously regulated by all of the professional bodies in the UK, doctors, nurses, social workers, physiotherapists, occupational therapists. They are all UK facing, and our standards of care and compliance is based on UK guidance from the Royal Colleges and NICE. So we're never going to get away from the UK system. I think we have to embrace that. But we do need to compete in a global market. And theatres, radiography, we know in orthodontics, there are key pressure points where these professionals could work anywhere in the world. Australia, Europe, America, Canada, Jersey. And so we've got to make our offer to recruit to these positions attractive. We've got to make Jersey different. They've got to see a good career progress. And I think that is probably where previously we've not had good foresight in thinking about our workforce planning and what we do to progress staff and to actually attract staff in the long term. So getting a good workforce plan is an absolute focus for us around the new hospital and, of course, the Jersey Care model.
What incentives do we have right now to draw people to Jersey? Obviously, we've spoken at length, and States members right this very moment are talking about all the issues with our ageing current hospital. So aside from just extremely high salaries, I mean, do we have any particular draws?
Well, we do. I mean, one of the things that is quite good about the Jersey healthcare system is that there is good support for continued professional development. So you get a much more generous offer of extending your skills than you would get in the UK. There's better funding for courses. There's better. We have broader trained staff across many of our disciplines. There's good funding in that domain. I think what we've seen from the Be Heard survey and what we feel when you get underneath some of the issues that we have is one of the great successes of Jersey is that we've been able to retain staff for a long, long period. And in many healthcare jurisdictions, that would be hugely successful. So somebody staying as a ward sister for 20 years is fantastic. You get good continuity, a legacy, great understanding of the system. But if you're the deputy sister and the senior staff nurse and you're working in that environment and you're waiting and you're waiting and you're waiting, that can be really frustrating. And I think we have that challenge in Jersey because we've had very long-standing senior leaders in positions, and there hasn't been as much movement as what I think we need. And so people can be trained and they get all these, good levels of accreditation and new skills, but they often find it difficult to progress because there's nowhere to progress to.
But obviously these senior positions are finite, so do you just create extra positions?
So that's where I think we've got to think differently, because actually all of that experience, all of that learning that you have from these individuals who've stuck with our system, who we've got to be really grateful for, that they've kept the system going and they've been able to run the services, they've got a huge role to play in how they develop the next person and the next person and the next person. And some of our changes that we want through the Jersey Care model give us that opportunity. They give people the opportunity to step into different roles, in different settings, and to have that ability to think about their promotion, their progression and their career. And I think that's a really good thing for a health and care system. In addition, the new facility that we would have in the future, in the new hospital, also adds a huge component then in terms of that attractiveness about the setting that you're going to be working in. So there's a lot to be optimistic about, but we just need to start getting that workforce plan aligned to some of these great strategic things that we're involved with.
I think that gives us a good opportunity to turn to the topic of leaders and leadership generally. One thing that we need good leaders for is when things go wrong. In the theatre services review, just to return to that, it said 184 incidents were reported for theatres between January 2019 and April 2021, the highest number relating to treatments and procedures. When the reviewer spoke to staff about this, some told him that they would not report something going wrong. The main reason, I'm quoting from this, was the lack of feedback and fear of being blamed, while some said they were unaware of who they were supposed to report to. So that's quite concerning, isn't it, that they don't feel that they've got that confidence to be able to speak to their leaders?
Yeah, so in any healthcare system you have to have effective raising of concerns. You have to have good escalation in how you report an incident. And the volume of incident reporting is often not the barometer you look at. Over-reporting can be a really, really good thing. And under-reporting can be a really bad thing. The most important thing is that you're learning. And that is one of the things that we expected that we would need to improve on, because we feel that that is a continuous part of any health and care system. So for us, we've had to introduce new things to make sure that staff are aware that when there is a problem, there's a procedure that is needed to be changed in some way in terms of equipment or whatever it would be, a pathway, that there is a process for them to raise a concern and there's a process for them to have feedback about that. That's why we've had to change our structure. We've had to make sure there is new roles around clinical leadership. We've got a dedicated doctor who's now providing that role, a dedicated nurse who is now working within that quality and governance arrangement to make sure there is continued learning, the safety huddles that we've had to introduce in the department, and that is how you start to establish good improvement and continuous learning and improvement in an environment.
So just to put it into context for people who don't work in the hospital, if I was a nurse and I'd seen something I thought was a bit wrong, what would I do? Who do I speak to, and what happens next?
So if you're a nurse and you think something is wrong, depending on the severity of something that's going wrong, depends on your reaction. So you're there as the patient advocate, and if you feel something is not right, you have a duty of care under your code of conduct to raise that concern immediately with the colleagues around you. So that could be the doctor, another nurse, other professionals, and you must do that. And staff must feel able to do that. And believe me, they do that. We have many incidents where staff will absolutely call out something that they're not comfortable with. Where it's a situation where there isn't believed to be harm, but the process isn't quite right, and there could be a miss in some way, then that requires a more controlled learning reporting, and something that needs to be picked up probably post-event. So it depends on the severity, but all staff in their professional code of conduct are absolutely aware of what they should be doing to make sure that they are keeping the patient safe.
Brilliant. So just looking at the report, it made 11 pages of recommendations. 6.5 were dedicated to leadership itself, and you've emphasised, how important that is. It says managers need to be visible and provide an authoritative but caring presence. So, as a leader yourself, can you kind of tell us, what does a good manager look like, and what should those who might not be living up to that standard be thinking about doing to change their attitudes?
Yeah. So I think there's often a language sort of complication here when we describe manager, and there's a lot of focus on managers in the healthcare system here in Jersey, and we've worked hard over the last few years to make sure that we switch from administrative management to clinical and professional leadership and management, because we believe passionately, and most healthcare systems are striving for this, that if you have clinicians and professionals in leadership positions, their management of the service is often more effective. And so our focus has been on how we build clinical professional leadership, which provides management function. So in this instance, we've absolutely focused on how do we build on what is clearly needed from the report in terms of that clinical professional leadership. So we've had dedicated roles developed, and we've got those people in post. They do need support from the more business side of things, and so we have clear what we call a task and finish group that we have every 2 weeks, where we all come together from the executive right the way down to the floor, where we look at our improvement requirements, many of those things highlighted within the report, and where are we with the journey on that. So some of that will fall to the nurse lead, some of it will fall to the doctor, some of it might fall to the business manager, and then myself, the medical director, the chief nurse, and the director general are also part of that forum, because we wanted to have very close working between the most senior executive leadership through to senior management, right the way down then to the floor, to make sure you've got closeness to it. And we're starting to see some good progress in that. So that isn't going to sort some of the recruitment challenges overnight. That's a longer term problem. But some of the more functional requirements, the process improvements, the reporting improvements, the quality and safety related improvements, we're making really good progress in that area, and that's exactly what we're trying to do. Visible leadership's important. It's a big organisation. I think, I could walk around it every single day, and I can guarantee you probably someone would say, I've never seen him, I didn't see him. I don't know what he looks like. And I've had that in the last 26 years of my career, from a nurse to a manager to a director. It's a complex environment to work in. I think it's really important you do spend the time, and every Monday we have clinical site walk around. We have drop-ins. We can walk to areas anytime we want to. We've got access to all areas, so we schedule that regularly as part of our daily routine as executive leaders. And obviously our clinical leaders we've just put into these new roles. They're there all the time. They're based in the theatre department now.
I think a lot of the improvements you've mentioned are quite kind of high level, a lot of procedural as well. But one of the things that kind of comes out of the report itself is, about feedback, the interpersonal relationships, both positive and negative. It highlights that perhaps, staff need a bit more of a pat on the back as a morale raising measure, but likewise, perhaps there could be a bit more diplomacy in delivering negative feedback. So, I mean, how are you training staff to manage those kind of requirements? I mean, what do you say to someone about their sort of leadership style?
People adopt different leadership styles. I think for me it's really important that our approach to leadership is leadership with compassion, and leadership with integrity. Because I think it can be a very difficult conversation you need to have with somebody, and I've had to have lots of those difficult conversations. But providing that you do it with integrity and transparency and you're open and honest, I think you often get to a better outcome, and might not have a member of staff who's happy with what you're telling them, but they will respect what you're telling them in the way that you're telling them. So our leaders do need support and training in that. We've got lots of support wrapped in. We've got the Faculty of Medical Leadership helping us with support for some of our doctors.
What does that entail? Is that kind of workshops or?
And tactics in terms of how you manage really complex situations. Doctors don't like being managed, and doctors don't like managing each other, and we don't particularly want them to in that way. We want them to work together in a much more interprofessional way that is very lean and that isn't requiring draconian measures. That's not the approach that we would want, really. So I think it is about nurturing that culture of how you want decision making deployed. I do, I've been here for 4 years, and it did strike me that there is a real draw on hierarchy in Jersey. There was a very strong hierarchical chain of command. You had to ask somebody for permission. You couldn't seek to do something yourself. A lot of our routine things that would be routine to me felt to be quite complicated and required lots of different people giving a nod. And some of those people in quite, senior, quite powerful positions. That is not the leadership style that we want as an executive team in health. We want evolved leadership. We want our teams to be self-leading and empowered to do so. We want assurance that they're doing what they should be doing for the good outcomes of our patients, and that they're working effectively. We're accountable for public expenditure at the end of the day. But our most important thing is that people are in a happy workplace and they're providing good patient care. And so we need to harness where we're getting good success, and we are having pockets of good success, and how that leadership can be spread broader throughout the workforce. Some areas are more challenging than others, I would say, in terms of how we approach that leadership challenge.
There's been a huge change kind of management programme, as you've rightly highlighted there. How do you manage some of the tensions between, some people or staff potentially thinking this is NHS versus Jersey's old way? You've kind of touched a little bit on Jersey's former way of doing things.
It's a fascinating thing for me. It feels that there is a very strange relationship with the NHS, and it's a complex relationship. So Our system is inevitably involved in the NHS. We use the NHS supply chain for our stock, our equipment, our drugs. We obviously the vaccination programme. As I mentioned, nearly all of our staff have come from the UK. Most of them have come from the UK. Even people who are not from the UK but have relocated to the UK and then come to Jersey. All of our training schools are with the UK, the deaneries. All our regulatory functions are with the UK and the Royal Colleges and the professional bodies. And I do think we wouldn't want to not be part of that. Having junior doctors trained in Jersey and nurses trained in Jersey is fantastic. And I don't know any other jurisdiction of 100,000 people that has that. So we want to keep that. But that doesn't mean that our organisation has to be like the NHS. And I've always felt that the benefit we have is that we're able to look at what's happening in the UK and in the NHS and beyond, and look at what's good and what we might want to do and what's not so good and we absolutely wouldn't want to do. And there's an awful lot that we don't do. And there's a lot that I would never want us to do, because I think that there are parts of the NHS system that clearly aren't working and that are having to change quite radically. I feel that in Jersey we've got the unique opportunity and ability to really harness the good, but to do it in our own way. So we're not trying to NHSify the system. We don't have the same constitutional standards, and we don't have the same framework. And our services aren't provided in the same way. There's a different island context. But we want to keep our links with the UK, and we don't want to lose those educational and that workforce flow. I think that's really important for us.
You said that you want to harness all the best bits of Jersey while accepting the parts of the NHS. What are those best bits? Obviously, our systems are very different. There's been a lot of discussion recently around primary care, for example.
So I think there's so much good about this system, and so much that the UK can learn from us, actually. For me, you look at some of the things that happen in Jersey, the strength of the voluntary sector is incredible. Some of the services provided by our partners in both mental health, physical health, disability support is brilliant. And they're things that you often don't have access to in the mainland, I have to say, from my experience there. I actually think our primary care system and our GPs are a real strength to Jersey. And I think that is evidenced in what we do. I think they've really demonstrated in the pandemic that having a familiar GP and somebody who knows you and understands you, gives good continuity of care, is incredibly important. There's so much evidence to say if you're seeing a locum GP and it's 3 weeks between your appointment and it's a different GP every single time, you're not going to get as good an outcome. And I think Jersey, whilst we've got some challenges at the moment, generally is in a better position than the UK in terms of that continuity. And we see that in our indicators. So in our A&E department, we've had less than 3% growth this year. It's a bit pandemic impacted probably, but that's still a very good position. And if you compare that to UK, they're seeing nearly 10% growth in some of the A&E departments there. And I think that's because people have no access to their GPs and they are simply flooding to the doors of A&E. I think our GPs are doing a good job in stopping that happening. They're also doing a really good job in managing our long-term conditions, because we're not seeing high admission rates to the general hospital. We're less than 3% growth there as well, and that's good. And then we are also seeing quite a low conversion rate from people attending our A&E requiring admission, which gives you an indication that you're probably getting really good community-based care that is keeping on top of people's long-term conditions and their overall care needs. I think there's more we can do, and I think GPs do need more support, and we need to start thinking about services in the hospital that can support GPs in a different way, quicker access to diagnostics, and connecting the system a bit better. But there are many elements here that I think are in a much better position than the UK.
I don't think we could conclude without turning to the topic of the hospital itself. Just again, this comes from the report, the Theatre Services report, but it looked at the efficiency of theatres overall and their usage. One of the things I wanted to point out was that at the time of the review, it was noted that several of the allocated private patient lists were underbooked, and it reports that one private surgeon was using his own private time to carry out unpaid work operating on public patients. So we've got a project currently with the new hospital that will massively increase the private patient service. So where did that come from? Was that a request from hospital management? Where was the kind of logic behind that, I suppose?
So there's been a lot of change with the public-private arrangement in care in Jersey, in secondary care in Jersey, in the hospital. And one of the things that we've been absolutely focused on, and it's been a ministerial priority for the Health Minister, we've always been embracing private practice in Jersey, and I think we have to be. A good proportion of the islanders are insured, and that's connected to employment here, and that's always going to be, and I think we're always going to have that need, and that can be a really good thing for a health and care system. The thing we don't want to happen is we don't want there to be a disproportionate offer between the public-private arrangement. So there is a period of time where you go beyond waiting that then becomes unpalatable in a public-private arrangement. So if you can have a procedure within 2 weeks privately, but it will take you 2 years publicly, that differential is too long. And we can't have that in Jersey. And so we've had to look at how we make sure that we protect public time so that we get down the public wait, and that we offer a reasonable private practice pathway time as well. And that's been challenging in the pandemic, I have to say, to get that, especially in the context of backlog. But we are working with our clinicians around that. We've tried different things. We've tried separate slots dedicated for private and public. We've previously had blended, where you've had some public, some private. and we're continuing to work through how we get those pathways right. The thing we're really clear about is the principles. We want both pathways. We think islanders want both pathways, but we don't want both pathways to have such disproportionate time between them. And so that's the key area of focus here, and that is really what the report from Felix has highlighted. Slightly pandemic adjusted, I would say, because every time we've obviously had 3 waves here thus far, and all of those waves have impacted on the way we would ordinarily do both public and private practice.
In terms of expanding the private service so greatly with the new hospital, was that a clinician-driven decision, or was that a political one? Where did that sort of idea come from?
So that's the entire specification for the new hospital is clinically, professionally driven. So all of the user groups have focused on what's required. All of our staff have been involved in that. And it's an estimate of the what's likely to be the growth element of the pathway. That doesn't mean that the unit has to be dedicated for that function. We could use the unit in what way demand is telling us to. And I think if there's one thing for me COVID has shown us is actually, we have to be adaptable, and clinical environments might need to change. And so guarantee of public-private activity is changeable depending on what your unscheduled need is showing. So that's what's driven it, really, is our capacity assessment of what those pathways will be. It is a growing pathway, and there is still significant demand in Jersey. We think there's probably demand that is actually leaving Jersey to have the pathway that probably could have that within the island.
And finally, just looking at the current hospital itself, we've heard so many stories of how the current building is not up to scratch and why it's just so vital that a new building comes as soon as possible. What would be your kind of, I suppose, message to States members right now who are debating the project?
I think I'll let the democratic process determine that, and I trust in the debate. Obviously, I think both myself and the senior leadership, Mr Armstrong, Rose, the chief nurse, and our Director General, we've been really clear. We think the case for change is absolutely clear. We need a new hospital for our staff. It is a difficult work environment. It's constantly requiring a lot of time, attention and support, and it's not optimum for our staff. And we think our staff need a better environment, and we think we found, obviously, the right solution. We've got good momentum, we've had good engagement, and we're in a really good position where I think staff are excited about the prospect of a brand new facility and what that could bring really for Jersey. So we're hoping, obviously, for a positive outcome.
Thank you, Rob Sainsbury. Express will be continuing to follow the twists and turns in the hospital debate and the efforts to address wider issues within the health service. Follow bailiwickexpress.com for the latest updates. If you enjoyed this podcast, please like and share. It all helps. The title track was I Shift My Weight by Luno. More next week from me, Fiona Potney, and the Bailiwick Express team.